Hi, welcome everyone. In previous sessions, we focused on assessment and management of pain and other symptoms in communication. And this session is an introduction to psychosocial and spiritual support for patients receiving palliative care. So when we talk about palliative care, what we really mean is whole person care. So not only pain and symptom control, but focusing on psychosocial and spiritual care. What do we mean when we talk about psychosocial assessment, versus a social history? So when you're talking about a social history, you're focusing on kind of tobacco and substance use history. And really a psychosocial assessment includes a person and environment perspective. And that's really a guiding principle in social work practice that highlights the importance of understanding an individual and individual behavior in light of their environmental context in which the person lives and acts. And I like this quote that I saw on Twitter. I'm tired of learning about who my patients really were by reading their obituaries and attending their funerals. The social history is reductive, seconds long, of lifestyle risk factors, a checkbox catalog of vices. It tells you nothing of their virtues. So psychosocial assessment, what is needed? This was a study that was done back in 2017 that looked at 105 hospice assessments to evaluate consistency in what they're looking at in their psychosocial assessments. And what they found that most didn't include patient physical functional status, preferences for treatment of care, awareness of diagnosis, prognosis, disease progression. Didn't include anything about communication or health literacy or cultural values. And when I look at this list, even sort of what wasn't included, it does seem a bit overwhelming to be able to go over this with a patient. But it's also important to note that this isn't information that you may get in one visit, and maybe information that you learn about the patient that you're caring for over time. And so here's some questions that you can ask that can elicit some of this information, really thinking about who is the person in this case. A question that you could ask is, tell me a little bit about yourself as a person, or tell me about your mom or your brother as a person. I like asking the question, what brings you joy? And dignity therapy came up with a question, which they refer to as the patient dignity question, which is a simple question. What do I need to know about you as a person to give you the best care possible? And that can really help you learn more about the more about the social and cultural aspects of a person. So total suffering. So the concept of total pain or total suffering indicates that there are many factors which contribute to the experience of pain and other physical symptoms. And each person is treated with the knowledge that physical symptoms really can't be treated in isolation. So a person has spiritual needs, they have psychosocial needs, they have intellectual needs, and all of those contribute to suffering. Ratner and Berzoff wrote this article in 2016 around the concept of sitting with suffering, where they describe feelings. Both of them are clinicians who work in hospice or palliative care, and describe feelings of helplessness when working with patients who have a serious illness. And the article describes how not all suffering can be relieved. And it's natural as a physician, as a nurse, as a social worker, as a chaplain to feel helpless. And the article really encourages clinicians to sit with suffering, not trying to relieve it, rather to be present and to listen, and the importance of listening and being present. And the article further goes on to describe that suffering is intrinsic at end of life. And a lot of what may come up for patients are, death anxiety, worry or fears related to end of life, or worries of maybe what comes next. Loss, not only the loss of, independence, but the loss of control, loss of hope, a loss of physical functioning. And with the loss of physical functioning can often come feeling like a burden, because as you have a loss of physical functioning, you'll become more dependent on family as caregivers and worrying about dependence on others over time. Loneliness, not only loneliness of being alone in a hospital setting or a clinic setting, but really the feeling of perceived loneliness, of experiencing the physical and emotional pain that they're going through alone, and worry for family. And really, again, kind of the idea of not trying to fix this or take away their worry, but to be able to sit and listen and to be present with their suffering. So here is just a brief case example of a 45-year-old with metastatic ovarian cancer who was admitted to the hospital with a small bowel obstruction, and her prognosis is likely weeks. She has 2 children, ages 13 and 14. And the nurse has reported that she's been crying a lot and worries about her children and asks for social work and chaplain help. And if this was a patient that you saw in clinic and you don't, have the resources, or you don't have a social worker or a chaplain within your clinic, what might you do? What questions may you ask to, find out what she's worried about or what she might be hoping for going forward? And so maybe just keep this in mind as we go through the rest of the slides. So psychosocial distress. So if we're thinking about the patient in the previous slide, there might be a lot of distress there. And really kind of figuring out the difference between depression and demoralization. So some degree of psychological distress is common for people with a serious illness, and we can screen for depression versus demoralization. So really depression, key things like hopelessness, helplessness, or screening for suicidal ideations. Demoralization, you can have moods that are sad and can suffer from, intermittent sleep disturbances or frustrations with medical care. But unlike the depressed patient, the demoralized patient can feel hope and enjoyment. So for example, a demoralized patient, they might have improvement in their physical pain and feel hopeful, or they might have a visit from their sibling or from their daughter, and they might feel emotionally better, during that visit. It's important to note that there is a higher risk for a history of mental illness, isolation, or hiding emotions, or if there's a recent bereavement, recent loss. And some questions that you can ask really to either determine the difference between depression or demoralization, or also just to elicit more information on your psychosocial assessment is, what helps you cope, or what helps you get through difficult times? What are you hoping for? And sometimes if a patient might say, well, I'm hoping to get better, you can clarify that by asking, well, help me understand what better might look like for you. Because that might not mean cure. It might just mean, well, I'm hoping that I can just physically be a little bit better so I could walk to the bathroom, or I could be able to, go to this important event that is happening in 3 months in my life. Screening for, how are your spirits, or how is your mood? And then again, the question of, what brings you joy, or exploring, before you got sick, how did you like to spend your time and what brought you joy? So continuing on with psychological support, we talked a little bit about this before, but communication, a non-judgmental presence in providing emotional support. Important to, validate emotions. It's common to feel, rather than saying this must be hard, or I'm sure this is hard, but I can't imagine how difficult this must be to you, because really we can't imagine one's individual experience. Managing physical symptoms is very important, because you often can't get to the emotional processing when somebody is in extreme physical pain. So there might be a clinic visit where someone's in extreme physical pain, and you focus on that for the first time, and then next time you're able to process and get to the emotional aspects of the illness. And encouraging what has worked and helped you cope in the past, seeking counseling, making referrals to outpatient mental health providers if that's possible, and then encouraging ongoing self-care. And again, some of the self-care could be explored by, what brings you joy. And maybe that was, being outside or going for a walk. And maybe some of those things aren't possible physically, but you can encourage new ways of self-care and strategize that together. And with social support, the unit of care is the family. So we also have to keep in mind that we're not only taking care of the patient, but the family, and how this illness also impacts the family. How are your children coping with your illness? Oftentimes I get a lot of questions of, well, I'm not sure what to tell my child about my illness, or I'm worried that I might tell them, too much. And I think a very practical response to that is, asking the questions that your kids answer. It might seem very simple, but that's a great place to start. And also exploring, tell me what worries you about your family. What are you most worried about? Families often need information and what to expect in the future. It can be important to explore, how do you best process information? How do you best receive information? Additional emotional support around grief, anticipatory grief, caregiving role, and legacy are also important, and what kind of legacy you may want, to leave. And then, practical support, providing basic nursing care, medication counseling. Sometimes that can just be so helpful to an overwhelmed caregiver. And encouraging also caregivers to engage in self-care as well. And I think I'm going to turn it over to Kathryn.
Thanks, Anne. So we'll have a little think now about depression and anxiety, both of which are common for patients who require palliative care. Some studies done in the UK showed that about 1 in 3 patients requiring palliative care had symptoms of low mood, and about 1 in 5 patients had clinical depression. About 18% of patients requiring palliative care had clinical depression. So it's common. So symptoms of depression, some of them are listed here. So it might include low mood, a loss of interest in everyday activities, a loss of being able to find pleasure in things that used to bring pleasure, feelings of hopelessness, worthlessness, or guilt. And for some patients, it might be suicidal ideation, which can be with or without presence of depression. It's important to remember that patients requiring palliative care will often have the physical symptoms that might be associated with depression as a result of their advanced disease. So it's worth remembering that symptoms such as fatigue, poor appetite, poor sleep, and poor concentration might be due to the disease process rather than depression. So we focus a bit more on the symptoms I've listed here. And we can use a tool to monitor symptoms over time and to also assess any response to treatment we might start for depression. One tool is the PHQ-9 tool, but check which tool is being used in your place of work. It's very important to assess and recognize patients who have depression and anxiety, because we can treat them, and treating them improves the patient's quality of life. So the management of depression, as Anne mentioned, it's very important to make sure that we've optimized the management of any physical symptoms. For example, a patient who has severe pain, it's going to be very difficult to improve their mood until you improve their physical pain. We need to listen to our patients and provide them with any information they need about their condition. If you're lucky enough to have access to mental health counsellors where you work, you can offer the patient some counselling support. We would recommend to treat depression with a selective serotonin reuptake inhibitor, or an SSRI. They can take up to 4 weeks to work. So it's important to remind patients and families about this when you start these medications, so they know that if they don't see any effect after a few days or a week, that's to be expected, and actually continue it for 4 weeks until we can see if it's effective or not. Review the response after 4 weeks, and you may need to increase the dose of medication. For patients who are in the last hours and days of life, it's probably too late to start an antidepressant to improve mood, because it does take the time to be effective. So it's not a useful medication for patients in the very last days of life. For patients with anxiety, as Anne mentioned earlier, it's important to listen, to validate their feelings, and provide any information they need about their condition. Sometimes anxiety is made worse by uncertainty. We need to think about other causes for anxiety, such as a side effect of any medications. One example of this would be steroids, so prednisolone or dexamethasone can cause an anxiety as a side effect. So review any other trigger that may be causing anxiety symptoms. We can give the patient some advice on techniques which can be used for relaxation, such as mindfulness exercises or progressive muscle relaxation. The mental health team may be able to help with this, or these are things you can read about and support your patients with. The choice of medication for anxiety depends on the prognosis. If prognosis is weeks to months, we'd recommend starting an SSRI at the same dose that we would use to treat depression. If prognosis is shorter, so days to weeks, we would recommend starting benzodiazepines and medications such as diazepam. And the dose is here, so either 2 milligrams 3 times a day, or half or 1 tablet, so 5 or 10 milligrams at night. Next slide. So when we talk about spiritual well-being, we can understand this as a feeling of peace, of being at peace. So spiritual distress occurs when people no longer feel a sense of peace, and it may express itself in different ways. And Anne mentioned some of these, such as a fear about the future, a fear of dying, or what happens after death. For some people, it's the distress is around a loss of identity or role, and this might be as a parent or in the work they did prior to getting sick. Others may express spiritual distress as a loss of control over what is happening to them. Or your patient or their family may be exploring the meaning or the purpose of what's been the meaning or the purpose of their life. Some people, when facing advanced illness and ill health, start breaking ties with their religion and the cultural ties, and this can be a sign of spiritual distress. For others, it may be a desire to reconnect with their religious and cultural supports. So there are different ways that spiritual distress can present. And as I mentioned, it might be a feeling of not being at peace, or searching for meaning, or a loss of hope or love or connection in their life. And we know that a terminal illness can often cause spiritual distress for patients as well as their family members. Next slide. So we can do a simple spiritual assessment for our patients to inquire about their spiritual well-being. And for this, we can use an acronym, HOPE. Some people may not want to talk about their spirituality, and they may not want to answer these questions. And so it's important to explain that it's not necessary. If they don't want to answer these questions, that's absolutely fine. They do not need to answer them if they don't want to. So the letters of hope are reminders of the different aspects of the assessment. So H stands for sources of hope, meaning love, strength, and peace and connection. And the question might be, what helps you through difficult times? What helps you through difficult times? O stands for organized religion. And we can ask our patient or family member if they practice an organized religion how important it is to them, and if it helps them. P stands for the practices, so spiritual practices. And we can ask, do you have spiritual practices which help you? And E is the effects on medical care and treatment. The effects of medical care and treatment. So we can ask, has being sick affected your ability to do the things that usually help you spiritually? For some people, this may be they find it more difficult to pray or to be in nature or to do the things that usually help them. Next slide. So how do we provide spiritual support for our patients? And Anne has touched on some points of this earlier on in this talk. So it's very important to, as Anne mentioned, not always having to take away the suffering, but just to sit with it. Okay, so we listen to the person's story with kindness and compassion. And we try to avoid giving answers or advice. And this includes sharing our own beliefs or religious practices, or recommending our own religious practices. We can use small prompts to encourage the patient or family member to share more. And these can be, tell me more about that, or what does that feel like for you? Or how do you know when you feel better? So this just helps the person talk through and explore how they're feeling. Sometimes the patient or family member may want to talk about dying. And avoid a false reassurance if that's the case. So just sit with it and listen. So patients and family may find meaning through different ways and connection through different ways. For some people, it's being with family and friends. For others, it might be through creative activities. And for others, they may want to have support from religious or spiritual leaders from their community. Some people feel reassured to know that the questions they have and the difficulties they're having are experienced by many people who are facing a life-limiting illness. So this can be a source of support for people to know that these questions, these fears and concerns they're having spiritually are common to face when having an advanced disease and advanced illness. Next slide. So in summary, psychological distress, depression, and anxiety are common for patients facing a life-threatening illness. So we need to remember that, remember to assess for them and to offer support and management where we can. Palliative care is not only interested in supporting patients, but also provides support for families. This may be support in terms of information, emotional support, and for some patients, for some families, it will be practical support. And spiritual well-being is important and may impact on physical and mental well-being as well. So we're looking at holistic care, listening and allowing the patient or family member to identify what helps them in difficult times can really help. Thank you. Next slide. And here's a list of references that you may want to look up for some more information on these subjects.